جدا في الورك شوب ده الريجيد برونكوسكوبي. الحقيقه الريجيد برونكوسكوبي is very important لو اي حد is going to work in intervention. فintervention it is a must to know how to handle a rigid scope. It's very important. In our department, it's my pleasure. I want to thank Professor Ahmed Al-Ra'a for doing such hard work to prepare all the workshops with our society, the Bronchology Society. It's a warm welcome for all of you, and it's a real welcome as well to my dear friend Professor Popovich from Serbia. Thank you for coming. And in the old days, we used to use we didn't have the fiber optic bronchoscopy, so we used the rigid scopes. I remember when I was a resident in the early 70s, 71, 72. I used to use the rigid bronchoscope under local anesthesia with the negus. And I had a very tough nurse, and she used to handle, and another assistant to handle the patient so he doesn't fight. But at that time, we learned how to do a proper local anesthesia.
Yes.
With the forks and how to anesthetize this area. And in the old days, we used to use as well the bronchogram through the cricothyroid.
Yes.
And that was really tough, very, very tough. So when I remember this, how many rigid bronchoscopies I used to do, I had the record on many hundreds when I was a resident, and it was really tough. So rigid bronchoscopy is very important. طبعا ما نهتمش كله بالفايبر اوبتكس. ده السيت اب اللي احنا ويوز، وطبعا انا مش هتدخل في الحاجات اللي بيقولها الدكتور عماد، هتكلمكم الديتيلز او الديتيلز. انا مجرد بدي انتروداكشن بوزيشن بتاعت introduction of bronchoscope is very important. Flexion of the neck وhyper extension بتاع الاتلانتوكسيدا عشان كله يبقى one line. دي مهمة جدا. الانديكيشن برضه انا مجرد touching introduction، كل الديتيلز هتاخدوها in details from Popovich Professor Ahmed. removal of foreign bodies، وملك الفورين بوديز عندنا دكتور احمد الرعا، مش هقول اللي بيعمله. massive hemolysis, tumor resection, dilatation of stenosis. الحقيقه اللي عايز اقوله الريجيد bronchoscopy، انا I love rigid bronchoscopy personally. You feel the power. عارف لما ماسك مثلا عربيه مثلا اللي هي عربيه سبق، عربيه قويه، بتحس بالباور بتاعه البرونكوسكوبي with a rigid bronchoscope. So if any one of you is gonna practice rigid bronchoscopy, you have to master it. وتاخد a good, if you're gonna practice interventional bronchology, interventional pulmonology, you have to understand and you have to train yourself how to proceed with the interventional bronchoscopy, rigid bronchoscopy. الفنتيليشن، الاكسجينيشن، حواليك كتيرة جدا. ازاي تاخد a good punch biopsies، ازاي تعمل dilatation للتراكيه اللي احنا بنشوف كتير عندهم ستينوزس ويبس، ازاي بتعمل دايلاتيشن ويوكور او عندك فورين بادي كبير عايز تطلعه. حاجات كتيره جدا. وستانتنج كمان بالريجيد بونكوسكوبي الحاجات اللطيفه جدا. في حالات اللي هي التوتال اوبستراكشن والسنترال اير واي اوبستراكشن، how do you core with the tip of the bronchoscope. You shuffle التيومر اللي موجود زي ما تكون بتقور حاجه جوه، بس طبعا قبلها بتبقى عامل كوترايزيشن عشان تعمل كواجوليشن ما يبقاش فيه بليدنج جامد. فدي برضو من الحاجات المهمه جدا. في there is a limitation of rigid bronchoscopy. في بلايند سبوتس ما بتشوفش الرايت ابر لوب unless بتخش بفايبر اوبتيك جوه. في distally located foreign bodies برضه ما بتشوفهاش قوي، بتدخل fiber optic through the rigid scope. Upper lobe ICU patients is difficult برضه انك تعمل لهم rigid bronchoscopy في ICU patients. وبيشنت عندهم cervical problems او عندهم trauma في النك، انك تدخله is quite difficult. برضه دكتور عماد هيكلمكم اللي عندهم cerebrovascular problems or cardiovascular problems. دي برضه it's quite important, it's complicated. Arrhythmias, respiratory failure, refractory hypoxia, unstable cervical spine, خدوا بالكم, maxillary facial trauma, inexperienced bronchoscopies. Please, if you're gonna proceed with a bronchoscopy rigid, you have to have somebody, a mentor or somebody trained to tell you how to introduce the scope. This is very important. Training from bronchoscopy, unfortunately, in the majority of centers, they go with the easy one, with the fiber optic bronchoscopy. If you're gonna, I'm saying this for the third time, if you're gonna proceed in your practice in intervention, you have to practice rigid bronchoscopy. Unfortunately, it's a part which is forgotten, and we have to promote this procedure. Postgraduate courses on rigid bronchoscopy should be encouraged, and that's what we're doing in our society since the foundation of the society 17 years ago. We're always promoting bronchoscopy and workshops in bronchoscopy and rigid bronchoscopy, and now we have a lot of live presentations of workshops in our department and in ASUR department in several hospitals. So thank you very much, and I'm going to leave the mic for my dear friend.
Thank you, sir.
Thank you very much.
Thank you, Professor Tarek.
And best of luck.
My professors.
Thank you.
And thank you, Dr. Popovich, for coming 3 times now in Egypt. Third time? This is
Third
third
time.
time
This
this
is the
year?
third time this year.
Preparing for the Egyptian nationality, maybe?
Of course. Yes.
Okay, and thank you for you all. Just want to prepare my lecture.
Yes, but we didn't have adequate options. We had only 30 antibiotics and intensive, but now they have put zero optic, but in case they don't,
أعتقد إنه عايز
I
شهر
don't
هنا.
mind zero. To be sure.
البطارية أنا بطلت.
Yes. Well, it's a little blurred. It works. At least it works. But really, I don't use optics when I intubate a patient. I'm looking at well, optics are expensive. If you break one, the insert will not get another one. So I learned to intubate all of them. I don't use videos, only use videos to film something. I don't use light source. Yes, there is a light source in the tube. We put it in the rigid tube, light source in the tube. Optics is especially when you have to perform urgent intubation, suffocating patient with diaphragm stenosis, then we use optics and rigid
Okay. Before starting the lectures, you know the bronchoscopy is progressing very rapidly, very quick. At first, maybe with the beginning of the fiber optic bronchoscopy, when Ikeda invented the fiber optic bronchoscopy, he described it as eyes inside the airways. And then with the development of the rigid bronchoscopy, they said hands inside the airways. And after invention of later things like alveolar scope and the navigation, what we say is physician inside the airways. So we're now inside the airways. So why rigid bronchoscopy? rigid bronchoscopy was virtually ignored by many pulmonologists for more than 50 years. We were using the fiber optic bronchoscopy. Actually, it was reintroduced into the practice of pulmonary medicine in 1980s. It's off. We need charging. So at first, when we used the Gustav Kilian, who worked at 1879 or approximately, he was an internist and he used a rigid bronchoscopy at first to extract foreign body. It was a chicken bone inside the right main bronchus. He extracted it successfully. And then the pulmonologist started to use the rigid bronchoscopy first. So the rigid bronchoscopy was first for the pulmonologist, not for the surgeon. Then after the introduction of the fiber optic bronchoscopy by Ikeda in 1963-64, we left the rigid bronchoscopy and we started to use the fiber optic bronchoscopy, all of us, and we forget about the rigid bronchoscopy till the introduction of interventional procedures like laser, cautery, cryotherapy, brachytherapy in the 1980s, and then it started to come back to us, the rigid bronchoscopy, to use it. So it was reintroduced into the practice of pulmonary medicine in the 1980s, particularly because of growing interest in laser resection of benign and malignant tumors of the tracheobronchial tree. Today, most experts would agree that the rigid bronchoscopy is desirable in management of patients with complex airway disorders. Still, rigid bronchoscopy is performed by many thoracic surgeons, most ENT, and some pulmonologists. So again, why rigid bronchoscopy? Why we are insisting for rigid bronchoscopy? Because rigid bronchoscopy is very essential in some aspects or some regions, like in bleeding or hemorrhage. Bleeding or hemorrhage, foreign body extraction, to take deeper biopsy when fiber optic specimen is inadequate, this obliteration of intraluminal component, dilatation of tracheal or bronchial strictures, relief of airway obstruction, insertion of stents, pediatric bronchoscopy, this is very important, and in the interventional pulmonologists and surgeons today. To start with the bleeding or hemorrhage, when bleeding is massive and not controlled, using the fiber optic bronchoscopy with its small 2 millimeter suction channel, access to the airways through the rigid tube allows selective intubation. So when you got bleeding from one side, for example, from the right side, we just may, the very important thing is to think about ventilation at first, not control bleeding. A, B, C, you remember that. A, which is the A, airway. So this is very important. So you got to make selective ventilation. You just leave the bleeding and to go to the other side to do proper ventilation till the saturation of the patient rise up, and then you come back again to the right side to control the bleeding by several means. I've mentioned now. So this is a very important selective ventilation, or insertion of large suction tubing to remove blood clots. You may introduce catheters inside. Neonatal catheter, for example, for suction, with proper suction of the blood clots. So it also allows the operator to stop bleeding by laser photocoagulation, by argon plasma coagulation, and also by cryotherapy. It's not mentioned here. Cryotherapy is very important in controlling the bleeding. First is cryo, second is APC, third is laser or electrocautery. And tamponading techniques with forceps, sponges of the rigid or the rigid tube itself. Just when you are doing debulking, for example, as Dr. Tarek said, when you do debulking, there is bleeding there. You just stay where you are. Do not remove the rigid rapidly. You just stay to compress what you have done here of debulking of the tumors. You just stay there till the bleeding stops. You are doing what? Compressing the bleeding side of the tumor. Ventilation also can be assured throughout the procedure, and the access to the airway is not hindered by a small endotracheal tube. And that's why the nephrologist is asking you always, you are going to work with fiber optic or radial bronchoscopy? If you say the radial bronchoscopy, all right. They assure the ventilation there by radial bronchoscopy. But the fiber optic is still a foreign body inside the airways. However, the radial bronchoscopy, no, it's a ventilating tube inside the airways. Second thing is the foreign body extraction. Although most foreign bodies today actually can be removed using the fiber optic bronchoscopy, many experts would agree that some foreign bodies such as nuts, dental bridges, impacted teeth, and coins are more readily removed through the radial bronchoscopy because surrounding granulation tissue can be removed easily by the radial bronchoscopy using the bulking technique, using the mechanical technique, using the electrocautery laser, using the cryotherapy, etc. It's easier to extend the foreign. What I'm saying is, when you see a foreign body by fiber optic bronchoscopy, it may be out. It may be out. But when you see it by radial bronchoscopy, if you see it by radial bronchoscopy, it is out. This is the idea. It is out. You have all means to extract the foreign body using the radial bronchoscopy. Surrounding gland tissue can be removed. Bleeding is more easily controlled, as I have mentioned before, and foreign objects are more easily grasped with larger forceps, with larger forceps, larger tooth forceps maybe. And these are some examples of foreign body extracted in my department. This is the bridge. Actually, it was from an epileptic patient, and I removed it by the radial bronchoscopy. There was a problem there to extract this through the vocal cords. You got to manipulate it to extract it from the vocal cords. This is a fishbone. I remember this patient, he was a pharmacist, and he was diagnosed as tuberculosis, right upper loop tuberculosis, and this fishbone was there covered by granulation tissue. The granulation tissue was removed using cautery, that's why it is burned here, and it was easily removed after that, and of course he stopped the anti-tuberculosis treatment. And this is the pin cap, that's it. Bottom of a coat bottom. Pin cap also. Not, in Egypt here, with the common foreign body in children is what? The commonest foreign body in children, nuts. No, nuts. Here. الفول السوداني واللب والبتاع seeds. We are enjoying eating it. However, in Europe, I don't know in Serbia or
in Serbia, small toys.
Toys,
Toys,
yes.
small,
In Europe,
small
it's
part
toys.
of the
But
toys.
here, it
They
is
are
nuts.
putting it into the mouth and it easily aspirated.
Yes, here in the nuts, the most common in pediatrics. This is the paper we have done here in Egypt. And in adults, the contrary, in adults, in Europe, I think it's nuts.
Yes.
المزة بتاعت الكحول.
Yes.
But here in Egypt is the
We have pins, huh?
pin.
Yeah,
Yes,
in
that's
Serbia
it.
also some parts.
Yeah, the scarf pin.
Muslims.
Yes.
You may give one to Popovich as a gift. Okay, so it's depending on the culture, depending on our culture, the difference. This is also a pin cap, and this is a chicken bone, a pin cap, and this is what we said, the scarf pin. Voila, that's it. So, what is the indication exactly of the radial bronchoscopy in foreign body extraction? So in acute asphyxiating patient with foreign body extraction, it is emergency. So we've got to use the radial bronchoscopy. There is no time to hear the click sound while extracting the fiber optic bronchoscopy. You know the click sound? You just grasp the fiber optic by the foreign body, the needle, for example, and then when you extract, it'll get away.
Yes.
This is by fiber optic bronchoscopy. It happens by fiber optic bronchoscopy. There is no time and asphyxiating patient for these. You've got to use the radial bronchoscopy immediately. And to ensure ventilation, of course. in infants with small airways caliper. So it is very useful to read rigid bronchoscopy here. I know that the diameter of the rigid bronchoscopy in infants is small to introduce both the telescope and the forceps. So we use the prism, you know, the prism in stores, in stores company. There is a prism that lightens the airway, so you may use the naked eye to extract the foreign body using only the forceps inside the channel. However, in chronic stable respiratory status, we use the flexible bronchoscopy. And this is the scheme to be followed in cases of pediatric foreign body aspiration. So if you have a history of choking on high risk object, if there are signs and symptoms or radiological findings of foreign body extraction, you've got to notice the radiological findings here, air trapping with expiration. This is a very important and very common radiological finding to be seen in foreign body aspiration, which is the air trapping, check valve mechanism introduced by the foreign body. Or with or without mediastinal shift or marked consolidation or marked atelectasis or radiopaque object, here we perform the rigid bronchoscopy. However, if there is no signs or symptoms or radiological signs, we consult the pediatric ENT to see what we've got to do. If there is no history of choking or history of choking on low risk object, if there's no signs or symptoms or radiological findings, you just follow up the patient. If there's signs and symptoms or radiological findings, you consult the pediatric ENT. In our university now, we have done another scheme. When there is choking, you go to the ENT directly, because with choking, the foreign body will be in the larynx or the upper trachea. That's right. So to the ENT directly, and if he cannot reach it, or the patient came in a calm position, elective, so we may proceed into it if we both hold to the surgeon, to the thoracic surgeon. Other thing very important to the rigid bronchoscopy, and why we do rigid bronchoscopy, is to take a deeper biopsy specimen with the fiber optic biopsies. This when the fiber optic specimen is inadequate. You see the large forceps we used in the rigid bronchoscopy. We take a very good bite, and there is no excuse for the pathologist to say inadequate specimen. This is a very annoying word. Yeah, inadequate specimen. As Atul Mehta said, when I'm doing fiber optic bronchoscopy, I'm not afraid of bleeding, I'm not afraid of hypoxia, I'm not afraid of desaturation. I'm only afraid of inadequate specimen. The annoying word we always hear. The possibility of saying this word by the pathologist is less. And the other thing is to do disobliteration, as Dr. Tariq Safat said, the disobliteration of intraluminal component. What we use the mechanical debulking or laser, electro, or cryotherapy. However, the cryotherapy is not indicated in central airway obstruction, as it takes a longer time, and also it makes edema of the tissues, so the obstruction may increase by doing it as immediate action. Mechanical debulking is very beneficial. Just you push and twist very carefully, but when you do that, you've got to see the lumen, the distal lumen. You've got to see it in your eyes, because you've got to take the line to the lumen. If you didn't see the lumen, please never to do debulking, mechanical debulking, or complications will appear, like perforation, for example. Laser, electrocautery, cryotherapy. What we do is to apply the laser at first to calculate the tumor, then do mechanical debulking, then we apply another laser or electrocautery or cryo to the base of the tumor, just to prevent its rapid growth again. Other things, in short, is dilatation of trachea or bronchial strictures, which is very common post-prolonged intubation. Very common. We see almost 3 cases per week, with tracheal strictures, to relieve of airway obstruction, to insert stents, especially the Dumont stent or the silicone stent, using these applications applicators. So we use here the rigid bronchoscopy for that, and of course in pediatric bronchoscopy is very beneficial also the rigid bronchoscopy here. An ideal instrument for many therapeutic procedures available to interventional pulmonologists and surgeons today. These include but are not limited to laser photocoagulation, electrocauterization or APC of endobronchial tumors, granulation tissue or benign lesions such as papillomas, hamartomas, lipomas and adenomas, laser resection of obstructive malignant lesions such as metastasis, malignant melanoma and bronchogenic carcinoma. This is in short the procedure of using the interventional techniques. Here taking a large biopsy for debulking. This is taking a biopsy for as a piecemeal, debulking as a piecemeal, taking multiple biopsy of the tumor. Of course, there is a bleeding possibility here is high. And this is the method of introduction. This is doing the laser or electrocautery to the patient. And other techniques for doing the debulking technique by the rigid bronchoscopy. Laser resection of benign tracheal and bronchial strictures, such as those that occur from post-intubation injury, lung transplantation, inhalation injury, and benign diseases such as Wagner, granulomatoses, tuberculosis, Klebsiella rhinoscleroma, and amyloidosis. We may here use the laser technique. As Ikeda said, there is more hope with the bronchoscopy, and thank you for your attention. Introducing to you now Dr. Popovich with how many cases? 45 cases? No, 45 minutes?
45 minutes, not 45 cases. 4 or 5 cases, I'm not sure.
Okay,
but I need
you
to,
take your time, please.
please, I need to
Yes, to plug it, okay?
plug this
Yes.
into my computer because files are too large to be transferred because it has a lot of videos.
Let me move this one.
If it's possible, thank you.
This is mine. No, this, I don't know. Sure. لا دي بتاعتك دي. لا دي هنا بتطلع هنا. مش كده؟ This is for the laser, the pointer, yes, this is for the pointer. That's it. Okay, دي ايه دي؟ دي الماوس مش عايزينه خالص مش مهم. It's charged, will charge.
It's charged.
Okay.
Okay.
No problem. I may move this.
Get my mouse.
Your mic, sir, and your pointer.
I'm old-fashioned guy. I like to use mouse more than touchpad.
Really? For me? Okay, got your mouse, okay.
Well, first of all, thank you very much for inviting me. It's a great honor to be in Egypt. And thank you to Professor Ashraf Madkour, to Professor Emad, who invited me here to speak. Well, now, how do we practically use rigid bronchoscopy? We use it in our department, we use it for diagnostic and for therapeutic purposes. I will present some of our cases and present some of our experience with rigid bronchoscopy. And these are our rigid bronchoscopes and needles and other things we use in our department. We have all sizes of rigid bronchoscopes, from bronchoscopes to children, rigid, 4.5 tubes, up to 8.5, 9, 10 rigid bronchoscopes for mechanical dilatation for stent placement. And Professor Emad was right. During last 20 years, we are practically facing the renaissance of the rigid bronchoscopy. Why? But in fact, in our department, we never stopped using it.
And we still use it, not only for interventional procedures, but for diagnostic purposes. And there is one thing, this is my teacher, Professor Emilia Suzic from Belgrade. She learned bronchoscopy in France,
Marseille.
and in Marseille, yes. And I learned from her, but also from our thoracic surgeon, Professor Mandaric, who was who was the founding father of interventional pulmonology in Serbia. And due to problems of financial nature, I learned first rigid, then fiber optic bronchoscopy. Why? Because fiber optic bronchoscopes were broken, they were never repaired, and when I started to do bronchoscopy 17 years ago, I learned rigid first. And when I obtained my first, we did everything with rigid. We started like you started, in triple anesthesia, transcricoid anesthesia, because there was no propofol. We used barbiturates for anesthesia, for sedation, and practically it worked. We had 90 degrees optics to look at the upper lobes, perform with special guides. We put flexible forceps and doing under fluoroscopy guidance even peripheral lung masses. We were doing biopsy of peripheral lung masses. And practically, when I obtained my first, when the first flexible bronchoscopes after many years was obtained, I thought, well, what a nice flexible optics for my rigid bronchoscope. It can bend actually.
Yeah.
It is nice. So what are really indications for rigid bronchoscopy? Well, we use it for transbronchial needle aspiration biopsies. I'm going to show it to you in
الجديدة دي يا اخوان.
and here is the rigid needle.
الجديدة دي يا اخوان خلي بالك.
Yes.
احنا بنعمله بالفايبر اوبتيك لغاية دلوقتي يعني.
This is 18 gauge rigid needle. We can use it practically as a flexible needle, but it doesn't bend as a flexible needle.
Yeah.
Of course, we are doing bronchoscopy rigid in massive hemoptysis, interventional procedures, laser, cryotherapy, stenting, argon plasma, and you heard it all previously. But what is in the center? In the center is always reasonable indication for the patient. Why am I doing it? It's the most important thing. Advantages and disadvantages. Well, there are only a few specific contraindications to rigid bronchoscopy. Cervical instability, maxillofacial trauma, obstructing laryngeal carcinoma. If there is obstructing laryngeal carcinoma, don't touch it with rigid bronchoscopy. Leave it to the ENT surgeons.
Yeah.
And, of course, laryngeal stenosis. You will break the larynx if you try to introduce rigid. You see paralyzed vocal cords, you see a narrowed space, you see laryngeal paralysis. Don't do it. You don't know what is below. Don't touch it with rigid. Let's put the go to ENT to put the tracheostomy and not touch it. Safety above all. And these are the needles. You can pass the needle for everyone to see. And we have semi-rigid, rigid needles. We have curved needles for stations 4R and 4L. And we have a straight needle, like this is for station 7, 11R, and 10L.
Wait,
Of course, I will give you the presentation. Don't worry.
So like,
Eh? So, how do we do it? In general anesthesia, we are using propofol and we are using myorelaxation because we have jet ventilation. Myorelaxation, why? Because it is saving propofol. Propofol is a significant cardiodepressant. And patients in which we are doing rigid bronchoscopy are not always in a very nice condition. So we are using myorelaxants. Patient is completely calm and we can do everything we need. Average duration of the rigid bronchoscopy is 15 to 20 minutes, but you never know, of course. And straight rigid needle is usually used at these places and curved for 4R and 4L. 4L is very hard to puncture, but it can be managed. And if bronchoscopic findings were normal, no extramural compression like in some cases of sarcoidosis, the rigid needle was used in the central canine, and here are the results. And this is the first patient. We practically, you see from the patient's complaints that it is not clear that it is sarcoidosis. Beta-1 microglobulin is slightly elevated, patient has night sweats. Okay, he's not scratching, he's not itching, but there is a suspicion, maybe it's lymphoma, maybe it's not sarcoidosis. Angiotensin converting enzyme on the upper level, and the other marker we are using a lot, hetotriosidase, sky high. So maybe sarcoidosis. It's vehicular adenopathy, right? But it is also mediastinal paratracheal.
And paratracheal, right paratracheal lymph node.
Yes.
This is very important for some.
So maybe it's not sarcoidosis.
Maybe.
So let's see. This is widened upper lobar carina on the right, and this is regional needle aspiration biopsy. That is how do we do it. But the momentum is the most important. Why?
Yes.
The first puncture is not important at all. First puncture is just a tunnel. Second puncture on the same place, and move it. Different angles, different size. And you aspirate all the time. And remove the needle. And on central carina, practically the same. I prefer to use it on the left side. Why? Because angulation of the left main bronchus. It's better to puncture here, especially when the central carina is not widened. If it's widened, you puncture at the most marked extramural compression. If it's not widened, I puncture on the left.
Yeah.
So, what was the diagnosis in this patient? It turned out to be sarcoidosis. Thank you very much. that was relief for us and for the patient, because there was high suspicion in lymphoma. But how do we do it? We do a lot of rigid bronchoscopies for diagnostic. It is 340 till 2015. Now it's over 400 per year. And practically in this group of sarcoidosis, you see we obtained, combining with transbronchial forceps biopsy, we obtained histological verification in 91% of the cases of sarcoidosis. And from this data, you'll see that with TBNA in stage 1, 88.3 positivity in sarcoidosis. In stage 2, 81.9 positivity. Even in stage 3, when you don't expect lymph nodes, when you puncture these lymph node sites, we obtained in 4 patients, we obtained positive granulomas for sarcoidosis results. And you see the needle different size. This is the flexible. Just the pointer is where? On the left, this is the flexible needle. On the right, it is rigid needle. You see the diameter.
Yes.
It's completely different. And what about sample adequacy? Take a look. This is big piece of tissue.
Silver.
And I see it's a lymph node. Why? Because it's black. It's a lymph node. And for sample adequacy, you can judge practically sample adequacy right when you see it, that this is on the left, this is adequate sample. As every needle, it can be used many ways. Like, if you want to biopsy a tumor which is prone to bleeding, you can use the needle to inject adrenaline, nafazoline, or cold eye saline into the tumor before biopsy or recanalization. Of course, if you don't have laser, if you don't have argon plasma coagulation, it can be a matter of choice. But I prefer, when there is a tracheal tumor, you will see in other cases, when there is a tracheal tumor very prone to bleeding, when we establish diagnosis with flexible bronchoscopes, I prefer rigid and biopsy because of the bleeding. So these are practically advantages. Needle size, sample size, practically assessment of sample adequacy is immediate. Mechanical momentum is very important when you are puncturing it. Reusable. Well, in Serbia it costs around 50 or 60 or 70 euros, and it can be used many times. And from flexible bronchoscopy in moderate sedation with conventional TBNA, you can proceed to rigid bronchoscopy and general anesthesia and rigid TBNA in a moment. When you have anesthesiologist, what is the difference between moderate sedation and general anesthesia? Add more propofol, add myorelaxant, intubate with rigid, and pam, 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 and you are finished. Especially in lymphomas. You know, we have a problem with hematologists in Serbia. Why? Because they want whole lymph node to be analyzed to see what kind of
Staging.
lymphoma is this.
Yeah.
And these big parts of tissue can be obtained only by rigid needle. By flexible needle, they say, okay, it's lymphoma, but we need bigger sample, and now what? We are sending either patient to rigid bronchoscopy or to mediastinoscopy, which is
Which
is
complicates
unacceptable, complicates things, and the patients are young and they are wasting
Yeah.
time.
This is stores.
Stores. Yes, shorts, right. And what about mediastinal masses? It's my instrument of choice when there is a massive bleeding expected on biopsy, and I prefer to use rigid needle better than forceps. Why? With needle, you puncture the bleeding tumor, aspirate, remove the needle, tumor goes back. And the bleeding is less prominent than with forceps. With forceps, you tear the whole surface of the tumor, and the bleeding is more prominent. And you can, of course, ventilate the patient during bronchoscopy, aspirate the opposite side, everything you can do with rigid. And there is a case of one man who was 65 years old at the time. He had cough, hemoptysis, and stridor, developed 2-3 months before bronchoscopy. In Serbia, this is a common thing. People are not going to the doctor unless they are very, very ill. So we have 85% of patients, stage 3, B, and 4 of lung cancer coming to the doctor when it's already too late. Patient on chest radiography, atelectasis of the right lung was seen, and the cause of urgent hospitalization was hemoptysis. Hemoptysis lead the patient to the doctor fastest. This is the symptom that leads patient to the doctor. Not stridor, not dyspnea, hemoptysis led the patient to the doctor. In the moment of hospitalization, atelectasis was more than 1 month old, so we had to consider 3 things: either biopsy, interventional procedure, or both. So we need diagnosis, we need to stop the bleeding, and first of all, we have to see what's going on inside the airway. It is the tumor in trachea, which is bleeding severely. After 1 biopsy, 2 or 3 biopsies with small forceps, the bleeding occurred and we had to do laser. I don't like to use laser to stop the bleeding. If we do use laser, it is on very low power, just to coagulate the surface of the tumor. Because we have also argon plasma, but that argon probe was broken. And we didn't have argon probe at the moment, but most of the time we are using argon to do the coagulation. But with this device inside the rigid bronchoscope, you have practically, it's a guide, flexible guide. You put the laser fiber inside, and you can put suction catheter just near the laser, and you can aspirate the smoke. You can ventilate the patient through the rigid bronchoscope practically.
With low oxygen.
With low oxygen, of course, but the oxygen is off when you are doing
Yes.
laser. Less than 40%, less than, it says less than 40%
But I
FA.
remove it.
But we turn off the oxygen while we are doing laser. And after we remove the probe, of course, we aspirate and ventilate. After the intervention, it looked like that. So practically we had to recanalize.
Yeah.
We had to recanalize right main bronchus. That is something I didn't want to do because obstruction lasted more than 1 month. It is not quality lung under under the obstruction. I didn't see the lower border of the obstruction, but I had to do it because of the bleeding. I had to stop the bleeding, and the only way to stop the bleeding was to remove the tumor. And this is the male patient, 53 years old, very heavy smoker. 3 years before admission to our pulmonology department, he had general anesthesia and he was operated because of ileus, some unrelated condition. Post-operative course was complicated by sepsis. He was intubated for a very long time and he was on mechanical ventilation for 32 days without tracheostomy. That is first problem. Second problem, 1 year after he was diagnosed and treated as COPD, which he had never before. Remember this, COPD or asthma doesn't start at Thursday evening. They don't start one day, I woke up and I have asthma or COPD. Asthma or COPD do not have abrupt start. So it was something else. It was misdiagnosed. It was mistreated as COPD. But the patient worsened. Okay, they said, pulmonologist said, okay, he's a smoker. Now, heavy smoker, COPD is something we expect, but symptoms worsened on therapy. And mild stridor develops, but no one recognized it. And the patient was on his regular checkup, one doctor, which we strongly encourage to do. In COPD patients, make at least one chest X-ray in 6 months. Patient is entitled to have 2 diseases. And smoking is not risk factor for COPD. It is risk factor for other things. Tumor in left upper lobe was diagnosed. Peripheral tumor. Now what? And this bronchoscopy was made by younger doctor in my department, and I criticized him about the bronchoscopy. See? Yes, this is flexible bronchoscopy. He did flexible bronchoscopy. I was mad at him. Why? Because there is tracheal stenosis. And he had the time just to look at the left upper lobe and look at this. There is a tumor in left upper lobe.
Yeah.
There is a tumor infiltration in left upper lobe. Something that you should never do. If the patient has stridor, start with rigid. Don't bargain.
Go out. I'm waiting for him
The
to go.
patient, and now he's calling me
Yeah.
to urgently intubate the patient. Why? Because patient is suffocating.
Suffocating.
The patient is cyanotic. Of course, we had to do something we called urgent rigid intubation. You don't have time for me or relaxant. Just no premedication, no atropine, nothing. Propofol, or sometimes without propofol. Go dilate the stenosis. And we did.
This is very easy for rigid bronchoscopy.
Yes. Dilated the stenosis, and through the rigid bronchoscope, I put flexible bronchoscope, took the biopsy, patient is safe. So the patient has 2 diseases.
Yeah.
Out of one, the tracheal stenosis, you see below the vocal cord, it was benign tracheal stenosis caused by prolonged intubation. But don't touch it with flexible bronchoscope, ever. Case 4. This is one patient who is really young, 48 years old. He suffers from laryngeal papillomatosis. Well, it was laryngeal papillomatosis diagnosed. And he was treated with CO2 laser in our ENT department. Maybe 10 or 12 treatments in last 6 years, because laryngeal papillomatosis tends to relapse. And he developed stridor. And of course, reasonable thing was to think that stridor is a result of another laryngeal obstruction. But it was in hospital in rural part of Serbia, when he was, where he was admitted. They saw intact larynx. Larynx was good. The space between vocal cords was sufficient. There is no reason for stridor, but the patient was not good. They tried to intubate without knowing what is causing the stridor. Another blunder, another mistake. Don't do it. If you have suspicion of airway, large airway obstruction, first bronchoscopy, presumably with rigid. If you don't have rigid, don't touch it. But something has to be done. They try to intubate, the tube stuck. Stuck, completely jammed below the vocal cords. They started with smaller tube, nothing works. They performed tracheostomy. Put the cannula. Cannula is not going inside. Cannula is stuck also. Now, what did they do? The patient came to me with the endotracheal tube, which was put into the tracheostomy, but size 5 or size 6 for babies. Endotracheal tube was here. And instead of cannula, size 0.5 endotracheal tube was placed. And, of course, we started with rigid, but I started with, I was guided with this 5.5 tracheal tube was here, stay safe, and patient is ventilated somehow. So what is the smallest tube which I start with?
8.
I started with 6.5 to be sure.
Yeah.
And tracheal papillomatosis.
Yes.
I had to
remove.
use rigid forceps to recanalize, just to make space
Yes.
inside. But the patient was safe, patient was intubated. I'm sorry, the quality of the picture is not good because
We can see.
you
It's all right.
can see.
Yeah. You remove the pieces, huh?
Yes, removing pieces from there.
This is the problem with papillomatosis.
Yes.
It was tracheal papillomatosis.
Yes, and after that, you see, after we removed it was maybe 2 weeks after the intervention. You see, on the place of tracheostomy, you will see papillomatosis. Here are papillomas. You can see it at 1 o'clock. There is papillomatosis. And but the trachea is recanalized. Now the patient can breathe, and tracheostomy was eventually closed. How did we treat tracheal papillomatosis? The rest we treated with cryotherapy. Same patient. This is rigid cryoprobe. You see the papillomas, and how do we treat it? Why cryotherapy? Because only cryotherapy does not promote scarring reaction.
Cicatrization.
Yes, cicatrization. Cryotherapy is killing fibroblasts, inducing apoptosis, programmed cell death of fibroblasts. So we are using a lot cryo instead. In some cases, even, you will see, we used cryo to save the patient from the stent. Just, there is a problem, of course, we use this in rigid setting because of the trachea, of the whole disease. You can use cryo with flexible bronchoscope, but really I don't recommend it to do. You can use flexible through the rigid or some way, and the major airway has to be secured.
You may do it at holidays.
Yeah.
It takes a very long time.
Yes.
By fiber optic, yeah.
Yes, by fiber optic, remove the scope, put the scope,
Put the
remove the
scope,
scope, and what happens to the vocal cords? They become
Edema.
edematosis. And now we have 2 diseases. Out of 2, you caused 1. So the patient doesn't need it. Another woman treated from COPD 27 years, myocardial infarction 1 year before bronchoscopy, prolonged mechanical ventilation, recovery, something typical for post-intubation stenosis, worsening of symptoms, stridor, but due to her limited function, lung function test, she was not a candidate for surgery. You know, in most of the cases, we are using dilation of the tracheal stenosis or mechanical recanalization in benign stenosis as a bridge to surgery. The gold standard for tracheal stenosis is surgery. But in cases, this patient is, for example, resectable, but not operable. So we had to manage somehow. Yeah, and you can see. We saw the stenosis, and in the matter of fact, you can perform radial resection of this stenosis. How did we perform that? Sorry, this is the material. It is not. Just a moment. I think I have a better video of this. Huh?
This is the papillomatosis?
No, this is not papillomatosis. This is it is just to remove that presentation view. It is not papillomatosis. It is after the recanalization and radialization. After yes, this stenosis, this patient. After radial resection, you can do radial resection of the trachea by argon plasma coagulation. You can dilate the stenosis and you can practically remove the rounding scarring tissue and dilate the stenosis. But it didn't end there because we had to do something to prevent restenosis. Because you see, after it is old stenosis. When you have old stenosis, you practically the scarring process is finished. You cannot do anything on old granulation tissue, on old scarring tissue. You cannot do anything interventional. But if you do mechanical recanalization, you can convert it into the fresh granulation tissue, and fresh granulation tissue you can treat with something. In this patient, we didn't treat her just with. No, this is no. This is the other patient. We did in this patient we treated her with inhaled corticosteroids, dexazone. We treated with cryotherapy of this fresh granulation tissue, and her condition improved that she didn't need for 1 year, I'm following her, for now 1 year she didn't need mechanical recanalization nor debulking. So she's living practically normally. Of course, she has COPD, she has oxygen at home, oxygen concentrator. But now there is no significant tracheal stenosis. There is tracheal stenosis yet, but not significant. And
Just for follow-up.
Just take a look at this patient.
Yeah.
Just observe.
It's a long segment, huh? Taking about 2 cartilaginous
Why
lines.
didn't I do radial resection in this patient? Because sometimes stenosis is holding the lumen of the trachea. You don't want to destroy stenosis. Trachea will become malatic. And if trachea becomes, you see, this trachea is malatic. I do radial resection, I do mechanical recanalization. Patient has to live. When I pull the bronchoscope out, and the patient is not going to be better because trachea will collapse, and now you have another problem. So we decided to do mechanical recanalization, just mechanical, pure mechanical recanalization of this patient. Repeat it with, we start with, for example, this is 7.5, then next 8.5, then next the larger tube. But in
at the subcision, 3 sizes at the subcision.
Well, you have to judge. You have to see. Jean-François Dimon had the saying, "Feel the wall." If you feel that wall can stand your intervention, you can do it. But recanalize enough, be modest. Recanalize enough just to restore airway patency. There is always time for another intervention. There is always time to do it next time. Just secure the airway, and next time you are going to do better. Of course, if you feel that after 7.5 or 6.5 you can go straight to 8.5, okay, but is it necessary? Just think, is it necessary?
How can I feel this?
Experience, only experience. Because I prefer not to do consecutive, well, not just experience. For example, if there is a risk for general anesthesia in this patient, every time you put that patient into the general anesthesia, you increase the risk of anesthesia, not the procedure, of anesthesia. So do the most things you can to do during one intervention, during the same intervention. But don't overtreat the patient. You will see, follow the patient. And
No force.
no force.
No force.
How do I do it? I wait the patient to wake up without removing the rigid tube. Then, patient starts to cough. You, of course, you provoke cough by aspirating and this, and the patient is opening eyes, starting to cough. Maybe it's not fully conscious. Move the bronchoscope rigid by looking and go proximal to stenosis, just upper to see the stenosis. If to see how the things are going when the patient is breathing without the tube in stenosis.
Just look.
Just look. If it's okay, if the patient is breathing good, if the stenosis is not collapsible, if it's good, remove the scope. If you need to do more dilatation, tell the anesthesiologist, give more propofol, then go for it. And I will show you another.
And what about balloon dilatation in these cases? What is the priority for rigid or balloon dilatation?
Or balloon.
Balloon.
I don't like it.
I don't use it.
Why?
I'm sorry.
It doesn't have the force for dilating
No.
the cartilage as
No,
the
no,
rigid
no.
bronchoscopy itself.
Balloon is good for even for
Minor
for
invasive.
stopping massive hemoptysis,
Yeah.
for example, to inflate the balloon, to stop massive hemoptysis, to block the airway. But you know, with balloon you can maybe dilate pylorus in the stomach. You can dilate muscular structures, but trachea,
It's like this.
no.
Recurrence like
And
this.
one thing, you inflate the balloon inside the trachea, you are blocking the airway. I don't like
Count
it.
for 15
Maybe-
seconds.
Yes, sometimes balloon can be used. For example, when the stent is not properly positioned in trachea, when the stent is wrinkled, you can use the balloon to, like you are using to iron the shirt. You are using balloon to iron the stent, to straighten these wrinkles in the stent. But it is only for the short time. I don't use balloons for that dilatation. It has no power to do it. Just a moment, I will show you if I'm not too boring.
بيعملوها بتوع الفايبر اوبتيك. بيعملوا بتوع الفايبر
I
اوبتيك
will,
عشان
I will show you
يقول لك عمليه
another
dilatation.
patient.
This is useless.
I will show you another
You're going to
patient
put
how
on
to.
The same in one day.
Current stain.
In one day.
We had the patient very similar to this woman. Worsening of COPD,
Yes.
short severe tracheal stenosis, and we dilated the patient, but we instead of putting the stent, we decided to put the armored tube, armored
Okay.
soft endotracheal tube.
Okay.
You don't have stents. You have to find other way to
Yes.
stabilize the airway. Armored tube is better than a plastic tube.
Of course.
So, after the intervention, when we remove the tube, This patient is on, you saw the nasogastric tube. The patient has nasogastric tube. Take a look at this. Okay, there are scars from the tube, but inside the trachea, and you see, patient has COPD, these airways are easily collapsible. The patient is obese also, but this is the most important part. There is no stenosis. Look at this. Partially collapsible stenosis, okay, but there is no stenosis anymore. There is no stenosis.
Not bad, huh?
Yes. The tube was inside the trachea and the lumen was preserved. After the mechanical recanalization, we put the tube.
For you got the armored tube
Armored
for
tube.
how long?
The patient had armored tube for 7 days.
7 days, okay.
Only 7 days. It was enough. And before this bronchoscopy, of course, you see the place of the stenosis.
Yeah.
You see, I was afraid that this here was tracheoesophageal fistula, but it's not. It is not. But out of two evils, I think the stent is in the airway, has indications, of course, but it is the worst solution. When it comes to the stent, to the stenting, you have to deal with the foreign body in the airways. So the idea of stenting for me is to put it there, to stabilize the airway, and to remove it as soon as possible, if it's possible. So you have to find other ways. If you don't have stents available, you have to find other ways to stabilize the airway. And that is all I have to say. You will see the practice. You should really start learning rigid bronchoscopy. You have to be able to exchange instruments during bronchoscopy, because it's vital, because it is your patient on the table and you have to manage. If the patient requires rigid intubation urgent, you do rigid intubation. Sometimes you start with rigid and then with flexible. Always combine techniques. What is the best technique? I will tell you. One that you have. If you only have rigid bronchoscope, so that is your interventional equipment. You have to do. You have to do with that. If you have laser, if you have argon, argon is for example for coagulating tissue. Very good for stopping bleeding of the tumor. But I found in forced coagulation mode of argon, I found the way to cut with argon because I don't have electrocautery probe. I have to cut something with argon. I have the modality to cut. Yeah. So use all the equipment you have, but be modest. Don't overtreat the patient. Just recanalize just enough to restore airway patency. And next year there will be a congress in Mayo Clinic in Rochester from June 13 to 16, and I hope that you'll be there to see a lot of things. World Congress of Bronchology is not designed for workshops. There won't be many for workshops on World Congress, but new knowledges are always presented and at World Congress, and in 2 years in Dubrovnik, near Serbia, in Croatia, we are going to have 5th European Congress for Bronchology and Interventional Pulmonology. So it is in 2 years. So
this is near to us.
Yes.
So we go there.
Yes, it's near. In Croatian Thoracic Society and European Society are organizing it. And thank you very much for your attention.
This is why we.
Belgrade.
All right, okay. Thank you so much, Dr. Bogovic, for your nice talk and your experience donating us. So we're going to open for discussion. Any questions? I leave you with Dr. Bogovic. You can see other rooms, okay? So
rotating movement, rotating, just rotating. And stay in the midline. Rotate and stay in the midline. Good. Excellent. Just walk. Be free with this. Like it. Very good. Excellent. Excellent. Now go to the right. Rotate the patient's head to the left, and you go to the right. Don't worry. Patient won't break anything. Optic will break. Don't worry. Everything you do it on patient. It won't hurt you. Okay, now together. The optic and bronchoscope are always traveling together. Good. Now, rotate to find a way how to enter inside this. You need more space. Then make more space. But not by pressing on central carina. How are you going to do this? Well, you are hurting the central carina. That's not good. So you have to rotate the bronchoscope and find a way how to enter into this hole. If you don't know how, better don't. You better don't. Now maybe you should try different way.
Yes, go on.
Go on. Just proceed, but be careful.
The shaft.
The shaft, you have to see. Just proceed with this. Slowly. You're not in a hurry. In real patient, it's much easier because it has natural lubricant, the secretions inside the bronchial tree. Okay, you cannot do it. No problem. You cannot do it, then don't. Don't hurt the patient. First, primum non nocere. No? But if you yes, you can. Huh? You're inside. So rotate somehow, you will find a way.
My hand is so short, I can't hear out.
Well, maybe we can move the patient more here to you. The patient is.
I will move this with my left hand. When I'm rotating, all the maneuver with my right hand. I fix this with my right hand.
You fix this with your right hand, and everything else you're doing with your left. So you find a way.
With my left hand.
Yes, but it's easier in the patient. You will see. It's easier in the patient. You have no lubricants here. You need strength to pull it out and to rotate. It's easier in the patient. Good. Now go back to central carina. Go back to central carina. Now there is no need for patient to be in this stretch position because you need to ventilate the patient during bronchoscopy. Exactly. And you are by rotating you are going down. Exactly. Exactly. Now, did you damage the vocal cord? No, you didn't. Good. Very good. Please. Just be sure the camera is properly orientated and this out. You are left-handed.
Left hand.
Yes, okay, no problem. Just this is out, this is good. No problem. You can intubate with left hand. You can switch hands during bronchoscopy always. I do flexible bronchoscopy is properly just here.
By left hand.
By left hand, I do it with my right. Why? I learned that. I'm not sure why. But if I need to take a biopsy, for example, from right upper lobe apical segment,
Yes.
I switch the hands. Oh, uvula, good. That is the first orientation point, uvula. Now, where are you going? First, your hand, first. What is wrong? What is wrong with this picture?
This is upside down.
It is upside down. You see? Tongue is up. So, you need to orientate your camera properly. Now, it's okay. Good. have to keep it in the midline. You can do it this way, no problem, just protect the teeth. There are special gum protectors from rigid bronchoscopy, like boxers have it like gum protectors. You can use it, I don't, but you can use it. Or gauze, you can put gauze between the bronchoscope and the teeth, if you don't have it. Eh? But now, tell me one thing. Okay, you are, so it's,
This one?
no. The camera is not at the proper test.
Make the wires medium. It's okay?
Eh? Now it's okay. Now it's okay. Now it's not. Just another try. Okay, good. Okay, now it's okay. Good. Now, don't go there. Just lift it like this. You need to see anterior commissura and rotate. You don't want to see larynx partially. Maybe in the upper part of larynx there is a tumor and you don't see it. If you go with rigid bronchoscope and there is laryngeal tumor, you will first destroy the larynx. Second, you will push the tumor inside the tracheobronchial tree. Now you have two problems. So you have to visualize everything. Okay, now the patient is safe, ventilated, everything is perfect. There is no stenosis in the trachea. You can rest and think, what am I going to do next? What is the sick side? Where is the sick side? Is it left or right? You see the source of bleeding on the left. So you need to do suction and intubate, ventilate the patient to the right. So you go to the right.
While lifting.
With the rigid bronchoscope. Tam. Okay, but you are tilting. You are to the right, to the left. It's not possible. Oh, good, excellent. Now find the way. Of course, not to hurt central carina, but you did it. And now, put. If you want to see something in the 0-degree angle, you will see with your optic. But don't move the bronchoscope. Bronchoscope is fixed. When you move the bronchoscope, optics go inside the bronchoscope.
I see.
Yeah, right. Go back. This is central carina.
You can go to the left.
No, we can't go to the left because it's too narrow and the head. And of course, when you go to the left, you use smaller tube, like 7.5. This is, I don't know, this is 10, maybe FRD-Mon 10, I don't know what is 7.5. Good. Now, take a special look on the posterior tracheal wall. Why? It is thin. You can make for fistula, but you can make fistula also with this thing. So if you are doing it roughly, you can make fistula, especially if it's damaged or it's an older person. Older persons tend to have flimsy tracheal walls. And sometimes you are not even sure if when the patient has tracheomalacia, you're not even sure, am I in esophagus or in trachea? What's going on? So be gentle.
Manipulation would help.
Go back. Okay. Good. Now you see complete. Now that is the view of the vocal cords I want to see. Now this is the view. There is a hematoma on this vocal cord. Close by intubation. What are you going to do? Hematoma on the vocal cord. You pushed it on adrenal. Not injection. Just this is also a way to do the treatment. Spray adrenaline. You can put suction catheter. Suction catheter is not just for suction. It works two ways. You can inject things with suction catheter inside, but suction bend. There is no suction catheter here, but I will show you. Suction catheter, inject, then bend the catheter, not because liquid will go back. Put it on the, then aspirate and go back. And don't leave the airway before the patient is secured. Don't leave the airway because the patient is technically intubated while you are in the trachea. If you're not sure what will happen, leave it here. The patient is safe. Go back. Excellent. Of course.
Thank you for
That's why are you for? Here for. Please. Good. It has to. Yes, yes, yes. You are doing it with right hand. Good. Now. Excellent. That is the point. Uvula? Okay, but stay in the midline. Stay in the midline. Now you saw the uvula. That is the midline. Uvula is the midline. So you have to go up and up. You need to see. Don't worry.
I look at the screen, not on the patient.
Of course. You look on the screen. Exactly. But okay, let me help you. Listen. You are too deep. You are not. Now you are at the now rotate that. No. It has to be inside the scope.
Okay, I twist with the left hand.
Good, but you're not rotating enough. Go back. Go back, incubate again with rotation. And it has to be out. Excellent. Now, you have to see whole larynx. Excellent. That is the leverage I'm talking about. Take a look. This is the leverage on the tongue. Now, rotate, rotate, or you will break the anterior commissura.
Like that?
Like this. Like you are. Exactly. Exactly. That's it. That's good. Now you're on the central carina.
Shaft on the lateral of the vocal cords or on the one side.
One side, another side. One side, another side. Just
But
like
the
you are,
short
like sharp. No,
Should be
sharp should not be on the vocal cords
of the lateral.
or on the lateral. Yes, it can be. You can intubate, but you always rotate. The pressure is not at one point at the time.
Rotate as a screw.
Very good. Now we need to rotate a little and just first you need to pull it out and then find a way. Find a way. Bronchoscopy way. Is it? It is. Go down. Go down. Down, down, down. You're going down. It's much easier in live people because it is rigid and friction is. Good. Now,
Go
good.
back.
No, you want to see what's inside.
Look.
You took a look. Good. Now, inside the scope and go back. So, the second piercing, the second punch, is the most important.
At the same point.
Same point. If I have quality material, if I don't, I use another point. So you see, at the angle, aspirating, aspirating, moving inside different directions. Out.
At the same hole.
Same hole. But if the sample is not good, I have mucus, I have something, it's not a good tissue, I see it floats, if it floats, it's probably cartilage. It's not good. So I have to find another place. How?
How many samples? 5?
4 to 5. Yes. If you have extramural compression on central carina, it's much better. It's much better for you because you just pierce at the most prominent extramural compression. But you don't go here because of the blood vessels. You don't want to pierce anything. And you don't go too much. You puncture in the middle, in the matter of fact. And this. But how am I going to perform it on right upper lobar carina? Well, let me see in this model. I think right upper lobar carina is good. First, let me find it. Okay. is right above it? Is it here? Uh-huh. It's rotated. The bronchial tree is rotated. So, here it is. Ah. So, can I reach it with this? No, I can try. Usually I don't do it with camera. Yes, I can.
Spare.
Here it is. You can do it. So, removal of foreign body.
Which
With the syringe. Yeah, good. Thank you. So, continue. You just need this simple syringe. Simple syringe for biopsy. Nothing. If you have syringes that can, when you here to lock it, that's good also. It's even better because your nurse has a problem here because she needs continuous suction, and you move her hand and the syringe and the needle and the whole system. If you have locking syringe, it's good to maintain vacuum. That's it. Anyone wants to try? Just don't pierce the.
I want to try.
Yes. Just don't pierce the carina.
But this negative suction created from first or after coming the needle and direct to
When
the
the
carina?
needle, when you pierce the bronchial wall, you don't apply suction before piercing the bronchial wall.
So I will put it closed first?
Yes, first close.
Yeah.
Yes. You move the bronchoscope together with the needle.
If you have to use it sided?
It's sometimes right, sometimes left. But left is better when because of the angulation of left main bronchus.
And about the scope, is out of the trocar
No problem.
shift.
While it's not a problem, you see, you can do it from here, even from here, you can do it. No problem, because the bronchoscope is not moving. If you, when you move the bronchoscope, you put the telescope inside, you move it closer, and you need. But I usually don't do this way. I intubate the patient. Nurse is bringing me this together.
Yeah.
You advance together, which is a much simpler way. You all the time you can see the point of the needle where it is going. But in the matter of fact, you don't even need to see it. It's important to know that it is here. So I'm here, and here is my needle. Now try it together.
I must associate the needle all the time.
No, you don't. Maybe in the beginning you will need. Okay, here is the needle. Just you need to know the position of the needle. Good. Now go down, together. And you always together. Good. Now you want to pierce. So you put the needle down.
Where is the needle?
Where is here is the needle. Okay, you are doing on the right side, for example. You don't need to rotate the patient too much, maybe just here, because optics is also optics is also very good because it brings your needle is in the position because it near the optics. Optics is stabilizing your needle. Exactly. So, but it is more to the anterior. Okay, you have anterior subcarinal lymph nodes which are enlarged. Good. But this is to, I use it as first, second, here. But what?
Punch.
Yes, puncture, and then do it like this. You don't puncture the bronchial tree. They will kill me. They will kill me. The representatives will kill me. I will break their only broncho boy. Please don't. But don't be aggressive with ventilation and with suction during needle biopsy. Why? Because if you are and don't change too many places of puncturing. If you change more than 3 times, there is a possibility the patient is ventilating. Pneumomediastinum. It is, however, this pneumomediastinum is not big complication. It is not endangering the patient in most of the cases, but it is very bad to see your patient with subcutaneous emphysema because of your intervention. So, don't change places too often. This is rigid needle. This is 18 gauge needle. It is rigid, you know. And you see all the time what are you doing. I like to, and you know, you in time you will learn how to control the depth.
Right from the left is the same.
Yes, completely. You will learn how to control the depth of the needle of the puncture. When you sometimes it happens, there is a highly vascularized lymph node below the central carina, and when you remove the needle, blood comes out, and that is this spike 4. Block press. Like this. Rigid bronchoscope can do everything that flexible does. Even better. Take a look at this. Oh, look.
Can we use
Yeah.
adrenaline also?
What?
With direct pressure?
Huh?
Can we use adrenaline?
Adrenaline.
Yes.
It's of no use.
As a
If you compression is in the 99% enough, but I strongly suggest you before the bronchoscopy check PTT, ENR, and if it's higher than 1.6, don't delay the biopsy. So, of course, thrombocytes, they say below, everything above 50,000 is safe. It's not. Above 80 is safe. With 50 you can maybe do some bronchoscopy on with flexible bronchoscope, but I don't do it. Better give infusion of the thrombocytes to the patient and then proceed with your intervention. If it's necessary. So compressing, it's very important thing you can do with rigid bronchoscope. So there is blood, put it here, compress like this. Blood on the central carina from the needle, the spike is on the central carina and compression. Same thing here on the lobar carina, compression. Just put it in 2 minutes in normal patient.
Compression by the side of the shaft?
Hmm?
By the side of the shaft?
Yes,
By the side.
yes, like this.
Yes.
Who wants to try next? Okay, remove first the bronchoscope to the central carina if you want to puncture central carina. You're going to